And really what we're talking about is load reduction. Like we have lots of ways to do that. We can restrict a patient's world and say do less, so that's a reduction in load, or we can do things to them so that they can, still enjoy the things that they want to do, but it's all load related. So it has an enormous impact, and I maybe showed this earlier. We have a group of patients that if you get them to manage the load properly, it's probably a 5 to 7 pound. Every pound, I tell patients, every pound you carry above your knee is somewhere in the neighborhood of 5 to 7 incremental load across the patellofemoral joint. So they understand. I'm like, look, you're sitting on the exam table, you have no symptoms. You jump off and you have a little bit more. You go up and down stairs, you have a little more. You carry your kid, your dog, or a load of laundry up the stairs, you have more. Just help them understand the perspective of how load really matters. And like, hey, no one's ever really told me that. Half our patients don't even own a scale, right? So never being afraid to talk to them about this. If it's done well, they appreciate it. So this concept of the bone is where we're going. And as I said earlier, if you're in the cartilage panel, we spend all this time and effort on cartilage, but the reality is the lowest hanging fruit is thinking about load, which is, in Europe they get it right because they don't always have cartilage procedures available to them, but the threshold to do osteotomy is incredibly low. So anything that could change load could be beneficial to our patients. And I'm starting to subtype my patients, and I know you guys are all thinking about this in terms of who may or may not respond. So if you think about those who are going to get biologics, whatever that may be in your mind, maybe that's those who have activity-related swelling, they have pain with and without load, they have sort of that stiff and achy knee. What we don't know is the nexus of load and worsening the inflammation. That's something that's not really well studied. But you could polarize your patients into two main groups, even though there's a lot of in between, that you have those with inflammation and those without. I can tell you those without, who have activity-related pain, dry knees, load-related pain, it's sharp, it's localized, those are not my responders typically to biologics. So just, you can start thinking about what else you can do for them, which is why that might fill into the bracing category. All right, so I'm going to just talk a little bit about the business stuff. I run a group. I'm the managing partner of a very big group. I have lots of help, but we have 950 employees. We have verticals with surgery centers, DME, X-ray, obviously MRI, CT, dabbled in pharmacy, but the DME has been a very important part of what we do. If you look at the current status of healthcare right now, what I can tell you is in our group we have about 50 physicians. Professional revenues basically just keep the lights on, and physician compensation without the verticals is basically just, you can see what you're doing with lights on, but it doesn't drive a lot of true compensation for physicians. And what's happening, it's been going on forever, it just depends upon what the nature of your reimbursement is regionally. The fact that ancillaries are continue to account for a larger and larger portion of what we do. So I give a lot of talks to groups on, beyond professional revenue, and so I'm going to focus, obviously the relevance here is the DME program, and share a little bit of our experience, but verticals in your practice, especially if you're in private practice, the hospitals generally don't get it, but in the private independent practice side, this stuff is really important because it's basically indirect overhead relief if you do this well. As it relates to anything ASC related or DME related, there are a lot of considerations, and it's somewhat ironic that the exceptions for in-office ancillary allow you and I to refer to our own ancillary for someone to get a brace. I mean, it doesn't even have face validity, but that's what the exceptions allow us to do. But you still got to be compliant. And basically, the main take-home here is if you have a physician comp model, you can't really pay your providers based upon what they refer on the ancillary side. So that's one area where that you have to be really cognizant of the compliance risk, which is you basically share ancillary revenue equally, but for some prospective things you can do based upon work effort and things like that, but you can't tie it directly to what people refer. It's easier to navigate that on the ASC side with some exceptions, but it's very difficult to do on the DME side, and I would just say be very careful. DME, it's necessary, but it's often an afterthought for a lot of practices. It provides branding opportunities. I go to a health club and I see people in our slings and our braces with our name on it all the time. So there's some intangibles there that you get from it, but it's a service component. So we're hardwired with bricks and mortar DME in all of our 8 offices. One of the biggest challenges we had early on though was inventory management. And I can tell you, companies like Innovus and others do a really good job in providing support services in that regard. So it's a tremendous revenue opportunity with the patient at the center. It provides vertically integrated care from an efficiency point of view. There's a bit of quality control because you control all these variables from the HR side and what your inventory is. And if you're delving into sort of this concept of value-based care, controlling everything through the patient journey, including DME, becomes very important. I will tell you that it is one of the more complex areas. We've gone through 3 or 4 DME managers. We have an amazing one now, in my opinion, but you're only as good as your support staff. So having someone who's very knowledgeable in all aspects DME, including injectables, can make or break this business. There are enormous complexities relating to reimbursement. The regulatory environment and the way they are labeled requires some pearls when it comes to documentation to get them reimbursed with insurance. And then understanding how you calculate margins is actually very important as well. We had sort of an eye-opening moment years ago. This is 2011. We're part of Ortho Forum, which is basically 100 private practice groups in our region. So we all share our data, and it gives you a sense of how you can benchmark how you're doing. So this is us on a per physician revenue in 2011. And we said, look, what are we doing wrong here? And we just had a lot of errors in our efficiency and business operations. So when you're thinking about bracing as an ancillary, you obviously have your brace types, you look at revenue opportunities, and then you look at best practices. So lots of brace types. I don't want to go into any further, but Seth sort of has gone through this. I'll just tell you that there's sort of those that are off the shelf and those that are customizable. And they offer different opportunities for the patient from a clinical perspective, but they offer different opportunities as it relates to reimbursement. So these are sort of all the best practices that we've learned over time. We're trying to optimize patient care. We deal with the insurance authorization and revenue cycle management all in-house. We have an on-site DME coordinator who provides fitting. He trains everyone. And basically any issues we have are handled in-house by this staff. These are sort of the 3 Ps, and basically you're dealing with people. Most of what you and I do when you run a practice, it's an HR. It's as much about HR as it is clinical decision making and providing good care. So you got lots of people that weigh into this when you're dealing with a DME strategy. Obviously, we shuffle products around a lot. Sometimes it's by what patient acceptance is. Sometimes we find products that are flawed, and sometimes we're just doing it because they're commoditized products, and we're just looking for the best margin and return on investment for the practice. And we have done a lot of, and I'll show you some results of grassroots efforts. We've segregated our specialists by specialty, if you will, and we look at basically the success of each specialty within our practice. Like the sports guys crush it, the spine guys contribute very little, the joint guys have a lot of opportunity in our practice, but they really don't understand it well because they're so focused on just doing a joint replacement because everything that comes into them is surgical. So it takes a lot of education and a lot of hygiene to manage the people, the products, and the programs. So some of the things that we've been successful with is EMR integration. So we use our EMR to help create custom order sets. So it takes the variance out of it, and you're not worried about an individual making a decision. It prompts you along the way. It provides us with dot phrase utilization, which basically makes sure we're compliant, we don't miss it. Then there are basically those that require pre-authorization, which are your custom braces, and those that don't require pre-auth. So the more work you put into it, the better the reimbursement, basically. We're somewhat brand agnostic. We do have a lot of variability in terms of product costs. You can't stock everything. Like this is real estate and its inventory costs, so managing a business, which most of you are not really probably paying attention to this, you don't have to, but I would tell you that it requires you to use your space properly and not, you have to, it's a balance of drop shipping versus what you keep in stock. So you're really running a business when it comes to DME. And basically, we're always trying to find braces that fit a diverse patient population because we're trying to minimize the amount of inventory we have for the obvious reasons. Just to give you a sense, we do analytics on all of this, okay? And we look at the codes that are involved for single and double upright bracing. We look at off-the-shelf braces. Coding is very specific to these custom fit braces versus off-the-shelf. We also have a specific workflow when you do custom fitting bracing. And just to give you a sense from Medicare, CF is custom fit, no TS is off-the-shelf. You get a sense of what the allowables are for these braces. So you can you have to decide, again, the balance of business versus clinical medicine, what's right for you in your practice, but it allows you to actually make economic projections as a ancillary for your practice. And when it's all said and done, I prefer you not take a picture of this. This is, kind of our data. I left out what I could that's sensitive, but this is what when we meet, we have our meetings every other Monday, and once a month, I present to our group and I say, look, this is the changes that since we introduced to, say, the joint section, you guys are not using icing effectively. I can't even understand why you don't use icing compression. We on the sports side are, firm believers that icing compression reduce narcotic use. Why wouldn't you do it for total knee replacement? They do use braces, but they use braces that are uncomfortable, and they don't pay attention to a lot of those variables on the joint section. Alternatively, our sports physicians are masters at it, and there's huge variability across specialties. So the hygiene that we have in our practice is I go to our section meetings. So when spine has a section meeting, I'll spend the first 10 minutes going through each provider saying, look, what are the challenges you're having in the office flow? Why is it difficult for you to use PT? Do you want to use PT? Do you need different specialists? Sometimes like, well, I need someone who does McKenzie. I use this vendor because they have McKenzie PT. So you got to really, as I say, I call it practice hygiene if this is important to you. And if you're, in the business of medicine, as I said, it's not all about seeing patients and doing surgery. You cannot run a practice unless you can't run an economically profitable practice unless you pay attention to these details. So at DME, we were just abysmal. And once we started to pay attention to this, the opportunities really presented themselves. So this is 21. I have other data, but I'm just showing you we're moving from the right. We were terrible over to the left, and we're much better than this now. We're over in the first quartile now when we compare to our peer groups who are in private practice. So we think it's good medicine, it's good patient care, it's convenient for the patient, and it's just part of the business of medicine. So in conclusion, establishing an in-house unloading knee brace program has improved our overall patient experience. Our custom fit revenue is superior to off the shelf by about 50% based on Medicare allowable, so you got to think about how you want to manage that. You really do have to have in-house revenue cycle management, billing, and making sure you pay attention to documentation to avoid compliance issues. The EMR has helped us immensely in this regard. And as it relates to unloading braces, which we use a lot, basically, this is one where you probably need to look at the different brace styles and see what works for your patients. And we've gravitated towards less bulky, unilateral. I have unilateral when possible, just because patient acceptance is high. But it's not going to be a one-size-fits-all, obviously. And you got to figure out what works best for you, and lean on your product reps to teach you these things, and then put them on and see what fits, just to get a sense of what these things feel like and your patients are going through. And this has been a big adjunct to do our basic care for our patients, both non-surgically and, like Seth showed, some of the surgical indications. So thank you very much, and if any of you guys have any questions, we have a few minutes left. Appreciate your time.